thank you very much for the invitation to speak, and David in particular to inviting me to speak. So we're going to talk a little bit about equine stem cell science, which is the main sort of regenerative medicine that we would use at the Royal Vet College. There are others, but we'll be talking about mesenchymal stem cells in particular, and in particular with their use in the equine superficial digital flexor tendon. That is the most commonly injured tendon in thoroughbred racing, particular jump racing, of course, more likely in national hunt racehorses than in your flat racers. Tendon injury is the most common limb injury in horses, and to give an indication of why when you see the amount of fetlock extension which occurs during a full gallop. The superficial digital flexor tendon is an interesting tendon. It's a very energy efficient tendon, operating at close to 100% efficiency, and acts rather like a pogo stick. You know, the horse essentially bounces along with minimal muscular effort. In fact, we often don't really consider that the superficial digital flexor tendon has a muscular component, but that has a muscular contractility of around about 2 millimeters. So it's minimal. This is very much about a spring which is being bounced on by the horse. And of course, that's why the horse can gallop and gallop and gallop for long periods of time, storing energy. However, of course, there is a cost to this. To be this efficient, it has to be being extended close to its maximal strain. And we know that it ruptures in the lab at around about 12 to 20% strain. And in gallop, we've recorded strains of 16%. So it's operating very much on that tightrope of rupturing or tearing. And of course, not just once, it's happening cyclically. And so as the horse gallops, it's going literally every single stride. And we know over time there's a degenerative change within the tendon. And if in fact a horse will injure one tendon and rupture it, then the other tendon frequently will show signs of degenerative change as well. And so with that in mind, you know, we must always be aware of looking at the opposite tendon if we see a tear on one side. So what we're looking for, you know, we're not going to sit here and pretend that the horse has no ability to repair. Of course it does. And in fact, horses who injure their tendons, actually pain is not a big feature of this. Those of you who are in contact with racehorses will know that when they injure a tendon, superficial digital flexor tendon in particular, they're only lame for maybe less than a week. But of course, we know that the repair process is literally only in its embryonic stages. So we're looking for regeneration versus repair, looking really to restore function with a reduced scar tissue presence within the tendon. We know if we're going to do that, we have three necessary components. We need the scaffold, which is the tendon structure itself. We are looking into potential methods of introducing a scaffold into the lesion. That's yet to manifest into clinical use, but certainly that's part of research. We need an anabolic stimulus. So simply loading the limb is an anabolic stimulus. So we often have these horses on exercise regimes, and we know that provides that anabolic stimulus. But likewise, things like platelet-rich plasma, PRP, autologous conditioned serum, so what is known as IRAP, is an IRAP2. These look to provide an anabolic stimulus as part of the repair process. And of course, you need the cells. And this is where mesenchymal stem cells come into play. And this tendon, this little diagram illustrates, you know, on the right we have the normal fiber pattern, nice, beautiful linear patterns of fibers with a crimp. This is normal, and this is the what happens when you have an injured component. It's coming from the injured lesion within the center of the superficial digital flexor tendon here. Got an infiltrate here, highly cellular infiltrate, and of course nothing like the organized fiber pattern that was there to begin with. So we're looking to try and get as much towards the image on the right here as we can. And one of the nice things about mesenchymal stem cells is we believe at least they don't rely on a single target pathway for action, and they communicate. They have a paracrine effect, as we call, on the local cells, and we think that's one of their major functions. We don't think that mesenchymal stem cells literally just convert into tenocytes and tendon cells. We know that doesn't happen, but it's the effect they have on their environment which is important. So we look at stem cells, just quite simply, what are they? They're capable of self-renewal. That's their predominant feature. They affect the formation of new tissue during development. So during birth and the embryonic stages of life through to fetal stages and birth, they are there to basically assist in the regeneration of tissue. And some tissues is a little bit better than others. Muscle tissue is a lot better, for example, than tendon tissue. So what are the sources? I've already alluded to that. We have your prenatal, so before birth sources, the embryonic stem cells. These will be around about 4 to 5 days post-fertilization, capable of forming every tissue in the body. But of course that does carry ethical issues, and you will of course see these sort of things in the news of stimulating new replicas of people, of horses and so forth. Of course it has been done, as we know, but of course there are big ethical issues and big restrictions on their use, which is understandable. We also have the induced pluripotent cells. These are somatic cells, so cells around the body you can induce down into, so they have characteristics similar to stem cells, but they are not in wide use either. They're quite difficult to work with. Fetal stem cells also have been used in the treatment of tendon injury a little bit later on in the gestation, and umbilical cord cells. And these have been used especially in France, where they've got something called Wharton's jelly, which sits in the umbilical cord, and that is a good source of stem cells and may well become useful in the future. Certainly well established for the recovery of hematopoietic stem cells, so the bloodlines are used. We also have, after birth, we have the adult stem cells, or mesenchymal stem cells, and these are much more differentiated. And these are present in a small number in many tissues, okay? And they're currently used clinically. And these are what we use at the Royal Vet College. There's 2 different preparatory steps: bone marrow, yet relatively few cells in an aspirate, only in the tens of thousands of cells in an aspirate. And so what we do is we tend to have a culture step in order to augment those up to the 10 to 20 million cells. And that culture step does take time. 3 weeks is on average. To get 10 million cells, if you leave them longer, of course, you get more. Fat is also another possible source, and this has been marketed quite heavily. These are mini-manipulated, but their advantage being is they are horse-side. There are some which require a 48-hour incubation step, but the concern here is we get a mixed population of mesenchymal stem cells, so not necessarily the pure cells, mesenchymal stem cells that we look to get following culture. So as I said, so they have a close association with development, and they can regenerate damaged and dysfunctional tissue. Of course, that's important. But we don't really believe that they can regenerate tendon. Okay, no one's pretending that happens, and we thought maybe that would happen in earlier days when we first started doing this back in 2003, but we don't believe that happens. But there is strong evidence, certainly, that they act via the immune system to have an immunomodulatory effect. They alter the macrophage influx and the types of macrophages. And these are white cells which secrete signaling hormones which will influence the scar tissue formation and the matrix which is laid down. So they certainly have some immunomodulatory effect, we believe. So why, we are particularly interested in them in the superficial digital flexor tendon, and because there are many other injuries which horses get. Why in particular superficial digital flexor tendon? Well, we know, as we said, they result in poor functional healing, but in particular, they lend themselves in particular to, in one way, they have a central core, okay? Because if you're something with a product, needless to say, it's got to stay there, or you've got to be able to actually get it in. Now, these will fill in, this core will fill in, okay, over time. It's just a tear, initially it's full of blood, just like you do. So if you cut your skin, it bleeds. As a central core, and then slowly over time, over sort of 4 to 6 weeks, maybe longer, it will fill in. Okay, so there's a ideal time frame with which to make the decision to inject these cells. So what's the process? Well, you can get these out of the tubercocci and the pelvis. We tend to use the sternum. Now the sternum is is just down here. We've got the 7 sternobra, and the last 2 tend to be fused. So we'll always scan it to make sure we are not going to put this Jamshidi needle, which is a large needle you'll see in a slide or two's time. We need to make sure we're actually entering the center of the sternobra. We do not want to be going into this little gap here, or ideally into this little gap here. So we mark quite simply with Tipp-Ex on the side, and then perform a sterile scrub. Why do we want to make sure we're not getting in the gap? Well, this is the heart just here. Okay, so needless to say, you need to make sure if you're going to put the needle in, that you're not in the gap, because what you're feeling when you put the needle in is pressure. Okay, when you hit that pressure, then you know how far to get in. The facials aren't necessary; they're just part of the show. So what you do is you mark your spot, and then it comes down to just like the hull of a boat. So it's almost identical to the hull of a boat, and then you just put the needle through it. Obviously, the skin beneath the ties. The horse is simply sedated here. And then you feel the tip, okay? And then you put your finger 2 centimeters down from where the skin is, and then just keep rotating up, okay? And at this point, you don't go any further, obviously, because we know where we are. And this needle then is just embedded. It's got a central core, which is taken out. And then this is a 10 ml syringe loaded with 0.5 ml of heparin, stop clotting, of course. We don't put too much pressure. These are delicate cells, so we just put just about sort of 3 to 4 mils of pressure. And this is bone marrow coming out. It looks just like blood, in fact. It's a bit thicker maybe, but it just looks like blood. So it's very well tolerated by the horse. You know, sometimes it's just a bit of local anesthetic put up here, and it's sedated, and off we go. Now you might say, well, oh crikey, that looks a bit difficult or a bit dangerous. We've got the heart just behind. Well, of course, but as long as you scan beforehand and you just go in that 2 centimeters, if you don't get any bone marrow, you don't push it in a bit further just to see, you come out and start again, of course. To date, there's only been 1 horse on the planet that we're aware of that is, obviously it's gone into pericardium, and that horse did drop down dead. But in the I think it's like 10,000 has been done, as long as you adhere to those rules, it is perfectly safe. So the bone marrow aspiration, and then next up we have our expansion into stem cell rich population over 3 weeks. As I said, this is a process which is very reliable. It's not, any culture step has the potential to fail or become infected, but provided you have a sterile technique, it's just fine. You can culture them for longer. Sometimes they're ready before 3 weeks. Then they're resuspended in the bone marrow supernatant decay. This is a spin down of the original bone marrow aspiration. And then it's returned to us, the horse returns to us 3 weeks after the bone marrow aspirate, and it's implanted under ultrasound guidance in the standing sedated animal. And then the horse undergoes a 48-week rehab program. Okay. This is just demonstrating, this is what it looks like when we get it back. Normally there's two syringe fulls of this volume. You can see the needle just coming in, and then as you inject, a little bit of air is evident, so you see the air being distributing down the lesion. What we normally do is have to inject a few different sites because granulation tissue is infilling the defect, and that will prevent the upward and downward movement of the stem cells. But again, this is very well tolerated. This horse has simply got a ring block just here. It's sedated, and the only nerve-wracking part is you've got a fairly expensive syringe here with lube and all that sort of thing. Doesn't go too hard to go, you want to drop it. But it's all fine. Then they enter this 48. So it's obviously a lot to take it on the slide, just to illustrate that it's a control. This is what all horses get, period. Okay, so it's very well controlled. And you'll notice in the bold here, we've got repeat ultrasound evaluations here at various points, usually when they start a big increase in work. And at the end of 48 weeks, they are back in full work. So they're doing a lot of counter work. This is not a 48-week rest program. Okay, this is a controlled exercise program. If we notice something on these ultrasound exams we don't like, we can hold them back for a few weeks or whatever it might be. So the program can be modified. Does it work? Well, that's the critical thing, of course. Well, there's substantial evidence for its efficacy in laboratory animals. So we know in rats and so forth that it's a very, very useful technique. But of course, the principal thing, does it work in equine tendinopathy, in the naturally occurring disease? Well, we know over the years it's safe. It doesn't, none of this sort of, is it going to grow an ear in the horse's tendon or something ridiculous like that and bone? No, it's perfectly safe. We've never had any problems. These are cells that differentiated quite far down the line, okay? These are not your embryonic stem cells. We know there's an improved quality of repair tissue from histopathological studies, so looking at them under the microscope in euthanized animals, and we get a reduced re-injury rate, which I'll come to just in a moment. So, if we look at these, you see plenty of these things, unfortunately, in the literature, the before and after. No therapy is complete without such things, but in the top, in A here, we've got a lesion here. We tend to talk about cross-sectional area and the maximum injury zone, so 30% cross-sectional area. This is the longitudinal. This is the deep digital flexor, superficial digital flexor tendon. And then this is what we might sort of expect to see 6 months down the line. And similarly, lesions here and just in here. This little bit of tissue just running down the middle here, and then how it looks 6 months down the line. So this is obviously what we want, but ultrasound is quite a crude assessment in reality. It literally is shades of grey, and we are actually looking at other ways of assessing the functionality of the repair. Just looking at this, we all look at this as vets at least, and we say, yes, that looks good, but actually we know nothing about function, really. We're just looking at what the fibre pattern looks like. This was published a few years ago now, when this is a naturally occurring tendinopathy. You can imagine the problem we have frequently is actually inducing these tears. There are two methods you can induce them through an enzyme model and through a mechanical model of inducing the tear. But of course, the most important thing is really, does it work in the naturally occurring tears? Now, I need to say they are quite hard to come by. In those clinical studies, the other speakers have been talking about doing clinical trials. Clinical trials in naturally occurring disease is difficult, but we have achieved that in 2012. And what we looked at is, in particular, re-injury rate. As I said to you before, these horses don't have a problem actually coming sound. The pain's not a problem. They're often sound within a week. There's the re-injury rate, which is up at 53%, which is a nightmare when you put these horses back into training, put all the work and money into it, and then they injure in their first race or when they hit higher training. So what we saw here, this is national racehorses, and what we were able to do, we compared back with two previous studies which used different treatment. The Dyson study back in 2004, where they used conservative treatment, the injury rate was up here in sort of 56%. Okay, comparing against those, like for like, we've got a re-injury rate here of around about 27%. Okay, and the O'Meara study here is when they used things like bar firing, superior check ligament desmotomies, and insulin-like growth factor, variety of different treatments. And again, the re-injury rate very consistent across the studies with controlled exercise alone and all other treatments, usually up in the mid-50s%, with stem cells roughly halving the re-injury rate. Okay, and these are a lot of horses. That's a big study for what we're trying to achieve, and considering we were sourcing naturally occurring treatments and naturally occurring. And then we've got the sport horses, where are similar things occurring as you're seeing. Conventional treatments is Dyson 2004. Not huge, 107 horses versus 68 horses in this group. And we've got a roughly halving of the re-injury rate again. In fact, it's just a bit better than half. Okay, so this is the best study to date. Of course, we're always seeking to improve, but the best study to date with regards to superficial digital flexor tendon injuries. A group over in the States, Frisbee and colleagues, did look at the use in stifle meniscal injury, not so relevant perhaps in racehorses, but certainly in sport horses. And meniscal injuries in horses are particularly have quite a poor prognosis, especially grade 3 tears. Grade 3 tears are the worst type of, the grade system is out of 3, and these are the worst tears. And without, just with arthroscopy and debridement, the prognosis is down at 6%, which is obviously pretty dire. Okay, what they found, if they actually, with this group of horses, those with grade 3 tears, if you add stem cells in after the surgery, so you go in surgically, you debride the lesion, you note at that point, because it's an arthroscopic grading system, that it's a grade 3 tear. You then aspirate bone marrow, and then you obviously got to recover the horse, send the bone marrow away, culture step, come back 3 weeks later and just put it into the joint. That certainly is a useful treatment when you say to the owner, look, this is 6%. We need more horses. There weren't that many horses in the study. I have to get it in the mid-teens, but certainly it offers some potential benefit. Interestingly enough, 9% of cases had joint flares, which essentially means they went through a period of quite increased lameness due to inflammation in the joint. Resolved with pain relief, but it's quite worrying in the first instance when it happens. So the future challenges, certainly, what is certain is that despite a considerable amount of research over the 15 years, and to be honest, certainly within the UK, fronted very heavily at the Royal Veterinary College with Professor Roger Smith leading it, we need to understand them much better than we do. We need to improve the retention of cells. We know actually at 24 hours, so autologous cells, at 24 hours, only 24% of them are remaining at the site. Okay, but as I said, we're not expecting them to act rather like, if you think of a conductor in the orchestra, they're not part of the orchestra, not part of the cells. They're part of the conductor, okay? They're influencing the surroundings, we believe. They're modulating the immune system and the immune response. There's a potential, if we figure out a little bit more about how they work, that maybe we can mimic mesenchymal stem cell function without the cells, what we might call stem cell inspired therapy, to avoid some of the regulatory issues. And the possibility of having cells, allogenic stem cells, so stem cells you can just buy off the shelf, which was part of our research license in some countries as well. More evidence of clinical effectiveness. There is only the one decent study really looking at clinical effectiveness. Quality control for clinical use preparations. This is a big factor because of obviously the possibility of introducing infection into very expensive horses or problems such as that, and expand their use to other species. We know the humans are the human field is very interested in particular rotator cuff injuries, this in the shoulder, very similar to SDF injuries in the horse, and there's considerable amounts of interest within the human field regarding stem cell treatments, but also in joint disease in horses, which we alluded to with stifle joint therapy, but also fetlocks, carpi, and so forth, and hocks. And really we've got a sort of a collaboration as all with these things really with national and international veterinary medical sciences scientists to collaborate and actually come up with much better studies. I mean, there's good studies, there's good evidence in laboratory animals, but in clinical cases. And also develop quality control standards. And we now just, I guess a small plug at the end now, we are now set up our own stem cell centre at the Royal Vet College, which will be operational probably in the new year. It's broadly in place, a lot of hoops to jump through. Mainly because historically those companies which have looked to set up stem cell therapies have failed simply because due to the low numbers. It's very hard business to make sense of, because actually in reality there's quite low demand for it just due to the small nature, small numbers currently going for it. So we set up a stem cell centre at the Royal Vet College, fronted by Professor Roger Smith, who's certainly the world-renowned, probably the expert in the world on these things, and he will be fronting that moving forward. So obviously I'd like to acknowledge Professor Roger Smith and Dr. Jay Dudia, who gave me some of these slides. And if you have any questions, I'm happy to answer them.
Yeah, we're going to do questions on this one.
Any questions?
Okay. We've got some from the online thing, we'll update you with those.
Okay.
We might do them on the slides.
No problem.
Thanks so much.
All right, thanks.